there are so many factors that are actually predisposed to obstetric fistula, which is like a delay to get to the hospital in time for a cesarean section to be performed by a qualified doctor. So you find that most of the time the mother stay home for many hours, so they're not able to get to hospital, so they work under the TPA, traditional birth attendant. By the time they reach the hospital, of course they're not able to be assisted because it's late, their baby dies, and they undergo maybe a cesarean section and they get a fistula. And most of them are young, so young mothers are actually at a risk of getting an obstetric fistula. Poverty, because again, these mothers are not able to really even get to the hospital in time. They don't have an ID, so they cannot even enroll in Linda Mama in the first place. They cannot enroll in NHIF because they cannot even afford the 500 shillings for them to get to hospital. So early marriage, one of the commonest causes of, because at the age of 16, 14 or 15, a girl is married off and she gets a first baby. The system is not prepared for her to have a normal birth. So these girls actually get obstructed labor. And then some traditional practices like FGM. Once a girl has undergone FGM, the next minute she's getting married, and then the next one is she's getting a baby. So these are like practices that actually predispose our young ladies to early marriage, early delivery, or early pregnancy, and then obstructed labor, and then a fistula.
What are the statistics of fistula currently?
On estimate, we feel that for every 1,000, we have maybe 2 or 3 of ladies in Kenya having a fistula. But on overall, there is like maybe 100,000 women who are allowed there getting a fistula maybe per year. And then there could be maybe 300,000 who have they have not been operated. They are actually awaiting surgery. So it's difficult to get statistics or the numbers because these women cannot come out and speak about it. The shame that comes with it, and then where they come from. They come from very difficult terrains or very difficult environments, so they cannot be able to be reached, and even the shame that comes with it. So they just walk around without even talking about it. Yeah, but the numbers that we can be able, like for example, operate per year is between 1,500 to maybe 2,000 a year, if there are camps. Like now, Gainokia does in a year about 500 operations a year, sometimes 600 operations a year, since the last 10 years or 12 years also. But the number you can get done in other centers through camps, fistula camps, now patch up to make about 1,000, 1,500 per year.
Fistula Gainokia has been in operation for about 12 years right now?
It's about from 2011 years, 12 years.
How is the trend for fistula currently as compared to when you started?
Yes, what I've seen now is that we have mopped up most of the older fistulas, because I remember that before we had fistula that came in 60 years later, 50 years later, 20 years later. Now I'm seeing fistulas that are 6 months old, 1 year old, meaning that we have mopped the previous number that was suffering at home. But again, we are seeing now new patients that come after surgery, for example, after the cesarean section, after hysterectomy. We call them iatrogenic. Iatrogenic are cases that occur when an operation has been performed. So we still have a long way to go, because now when obstructed labor has been managed to some extent, and then we have now patients coming in after surgery, then it comes in that we need to re-energize ourselves in terms of training our doctors now, so that the number of fistulas that occur after surgery is actually minimized. It's not possible for you to eradicate or eliminate totally patients coming in for surgery not getting a fistula, but you can reduce the numbers, because now the numbers are increasing, maybe up to even 10%, when we should be having less than 5% of cases that occur after an operation. A patient has gone for a hysterectomy because of fibroid, a patient has gone in for a cesarean section, and that patient gets a fistula. That number should be reduced to less than 5%. but now we are at 10%. Other countries in the region maybe 25%. I think we need to reduce it to 5% so that fistulas can be eradicated in general.
Unfortunately, according to Dr. Mabea, fistula stigmatization also extends to medical practitioners who shy away from giving care and reconstructive surgeries to these women.
The trouble has been that we have kind of a stigma, even from our own doctors, in terms of fistula care. First of all, this condition is thought to be complicated. So the fear to do it comes in. Then I think getting a patient to pay for this operation is almost impossible. 90% of patients who come to gyno care, for example, or maybe even more than 90%, cannot pay for the cost of the surgery because either they are very poor, they don't even have an ID, they don't even have an insurance, NHIF, for them to pay for the cost. So they cannot raise money even to pay for the doctor, money to pay for the hospital. We rely on well-wishers fundraising to raise money for our fistula work since 2011 when we started doing fistula work. So there is a stigma among even our own colleagues about how difficult the procedure is, and also these patients are not able to pay anything. So that also stigmatizes them not to get access to healthcare. And then there is also continuity. When doctors get trained, you find that they have just left. They don't continue practicing, and then we worry, why do doctors get trained and then they just stop, they don't operate. Yeah, so there's a lot of stigma around fistula, right from the patients, the community, and even the clinical personnel. We have there are serious issues around maybe how do we get the doctors into learning fistula care. I've maybe done more than close to maybe 8,000 operations since now 2004, 2002 actually. When I started doing 20 years now, I can say I've been doing fistula surgery. And within that period of time, I've trained tons and tons of doctors through the residence program. I've done almost 80 residents since 2014 to learn fistula surgery. And then I've now trained others either from Kenya or outside the country through the FIGO, Fistula Foundation, the UNFPA, JPIEGO. Those are like organizations that have been actually supporting doctors to get training. So I can say I've trained several hundred doctors to do fistula surgery. But when you look at the action on the ground, the ones who are practicing, they are extremely few. And then also there's a bigger picture on how many specialists are in Kenya right now. Maybe per year the country produces maybe less than 100, maybe 50 doctors in a year, obstetrician gynecologists. And these doctors are supposed to be actually, they are low below the WHO recommendation for obstetrician gynecologists, that for every maybe population of 5,000, we should have maybe one gynecologist. But when you see that the country is producing just about less than around 50 obstetricians for the whole country to be distributed to the entire counties in the country, others also retiring and also others are leaving work. So you realize that we have a very short, few numbers of specialists, obstetrician gynecologists who can be able to cover the entire country. And that's easier because we find that some counties do not even have gynecologists. If they have maybe one.
With that in mind, what can be done to change this view and ease the fistula national burden?
So I think we still have a serious challenge because there are only 3 schools that train gynecologists. That's Moi, Kenyatta, and Aga Khan, that train specialists in different areas, including now obstetrician gynecologists. So I think we still have a challenge in terms of specialty training. I think that's why the numbers do not cope up with the population, so that you find patients come to the hospital, they don't get enough access to specialized care. And that's why maybe the care is actually not at optimum level. The last 20 years, we have been working with organizations from out of this country, UNFPA, Fistula Foundation, the AMREF, and very little has come up from the Minister of Health. But at the moment, the Minister of Health now is coming in initially to start a curriculum for training both doctors and nurses and other cadres that are involved in fistula care. And I believe that this is one way maybe the government can help. This is from the national government, and I pray that maybe the county government can also come in and also try to put in systems to do what we call prevention, fistula prevention, because fistula is purely preventable. And if the national government, the county government comes in, because I said earlier, initially there was almost international community organizations from outside who have been supporting fistula care. But if the Minister of Health has even a fund that is put for fistula care or even prevention, then I think that would be great. And I think there is some indication that the Minister of Health, under the Johnson & Johnson, JPEGO, they want to start a program first to basic curriculum development, and then after that they might be able to really move. They're starting from Makueni County, they don't want to move to other counties, and I hope it can be a nationwide kind of event to help in terms of prevention.
Other than this, there have been individual efforts also aimed at easing this burden, including hospitals like Gynocare Women's and Fistula Hospital.
The Gynocare started way back in 2011, and we have been working for the last 10 years, or more than 10 years. And we are located here in Eldoret, Uasin County, and basically the main hospital is based at Uganda Road, opposite Pipeline, Huruma or Mutimoja. And then we have a sister facility in the center of the town called Gynocare Eastern Avenue Hospital. All these two facilities actually help to get women who come in with fistula, and then we kind of prepare them for surgery at any given time. And fistula surgery in Gynocare is free of charge. If a patient has an NHIF, then NHIF can support that patient. But if the patient has nothing, and most of the patients have nothing, we operate them at no cost for this long period of time, 11, 12 years now. We do that operation at no cost. We don't charge them any money for even bed, for food and everything. Remember, fistula surgery patient overstays in the hospital maybe 2 months, some say 1 month. Within all that time, we don't charge them anything. For the young ladies whom we discover they can go to school or they can do vocational training, we even have a program called Beyond Fistula. We put them through that program at no cost again, so they are able to be empowered, given that during their fistula period they did not do anything. They were worried of going to the church, going to any social function, going to college, going to school. So they were like stigma, ostracized, and they were living in the house. But when they come at Gynocare, they get treated. During their treatment, when they feel better, we train them now. We try to see where they can go. Vocational training, school, some of our girls are in school, and then some are doing what we call income generation, like cloth making, basket weaving and all that. So we try to separate them into different areas, and after the treatment. So the treatment is free, the training is free.
How do you get your funding now that treatment is free?
Yes. Yes. Yeah, for the last many years, through organizations like Freedom from Fistula Foundation, that was the beginning. One by One came in from the US. Freedom from Fistula Foundation was from Scotland, then followed by One, that was from the US. Then UNFPA came in, and then Fistula Foundation has been supporting us since 2014 up to now. They have been supporting all the operations. In fact, they supported most of the part of the construction of their main hospital where we are now. So Fistula Foundation, but we have not had any support directly from the Ministry of Health. In fact, we don't even have what I call a tax exempt for this fistula work we do, despite the fact that we have even applied for tax exempt for specifically fistula work. But we have never been given that recognition for tax exemption for fistula care work. since the last 2011. We have applied for it, but we've never had. But I've had recognition from the Save Children organization based in the US, where I was recognized as in 2014 as a top fistula care doctor in the world. I was recognized by my own organization called COGS, Kenya Obstetric Gynecological Society, for the work I do for fistula work. I was also recognized by the International Society of Obstetric Fistula Surgeons in the world. That was in November in Mozambique. As one of the top world fistula surgeons, I was awarded for that. And at one time I was actually nominated for a presidential award for my work. I was nominated. I didn't get the award, but I was nominated, which was kind of a big honor. So I think from my own perspective, I'm very happy that some organizations have recognized my work, and I keep working hard to make sure that fistula is eradicated and mothers who have fistula are actually treated and they have a better life after.
You mentioned that you've done over 8,000 surgeries.
Yes.
Approximately how long does one surgery take?
Well, in general, fistula surgery is very difficult sometimes. Having been in the fistula world for close to 20 years and having seen all types of fistula cases actually, one case can take you 1 hour and you're done. Well done and complete, and it's successful 100%. One fistula case can take you 8 hours, 5 hours, 8 hours. You may succeed the first time or you may succeed the second time. But again, over years, you keep to learn, you keep on learning and getting the skills. So a surgery that was taking you 6 hours comes down to 3 hours. Once you're at a top surgeon, then a very difficult surgery can actually take you about 3 hours. But initially when you operate, you spend 7 hours in that operating table. But even if in the hands of the best of the surgeons, I still take, in some cases, 6, 7, 8 hours operating a case. Good enough is that more than 85 to 90% of these operations are successful. The leakage stops and they're able to lead a better life. Even if it ends up doing what you call diversion. Diversion is the end point of fistula care, when you cannot do anything else. The mama has no bladder, so you create a new bladder from the intestines and create a pouch for this patient to use as a bladder. So we have done that many times, maybe 200 operations like that one in that kind of care, and the patients are happy and successful. So I think so it requires resilience of the surgeon, time. You need a dedicated surgical team. The nurses have to be really friendly to the patient. The anesthetist has to be there, very friendly to the patient, and also the social care workers are really very critical, because now these are the ones who help this patient recover after this very long surgery.
However, regardless of most women needing one surgery, some complex cases will need more surgeries in order for the woman to fully recover.
Some patients can even undergo 10 operations. Patient goes to primary hospital, they do an operation like a cesarean, a fistula occurs. Patient goes to the second operation, they do a colostomy. Second time the patient goes now for the reoperation, it fails maybe in that center. Patient refers to gyno care, for example, to now a specialized center for fistula care. The first operation maybe we do to close the defect. Second time we open up to return back the colostomy. Third time now we go to do the urine repair. The urine repair does not work because the bladder is missing or the urethra is missing. So sometimes we do more than 10 operations in a case. Yes. And those are really things that really make these patients so special, because they are able to withstand all those operations. Some have anemic because they come from the areas where, like now, there is no food. Patients, those ones who come, they are malnourished, they have no blood, they have to be transfused, they have to be given nutritional care. Some have contractures in their legs, they need physiotherapy, orthopedic care. So at the end of the day, you find that our mama has gone through 10 operations. But the good thing I say is that most of these clients who have gone through those operations, at the end of the day, when we do our final surgery, they help actually to get back to their normal life despite all those numbers.
Thank you so much. Now, based on that, what would you tell women out there who probably know that they have fistula but they don't know where to go?
Yes, for patients who have fistula, they are leaking urine and stool after delivery. In fact, there are those who are born with congenital problems. There are those ones who have had cancer and they are leaking urine and stool. Those ones we have at Geno Care, we offer them free fistula surgery. That means they don't have to pay anything extra. They just walk to the hospital and we give them a free fistula surgery. And that's what we have been doing for the last more than 10 years, and we still continue doing the same. For those ones who are like expectant or they're pregnant, they can actually get to hospitals in time, so they can get a cesarean section or normal delivery in a center which is qualified for that, so that it can prevent. But once they have gotten a fistula, because again they can get to hospital late, then the fistula has occurred, or they go through a surgery, then a fistula occurs. Our center does free fistula surgery, and we are ready. We have enough personnel to continue giving them this kind of care. For medical equipment, I think those should be tax-free. Fistula equipment, because for sure, as I said, almost 90% of the patients who come with fistula are kind of patients who are paid for by well-wishers. Equipment sent by well-wishers to come and help poor women who have fistula, those ones should not be taxed. Facilities that actually do like free fistula operations should have some tax exempt in that area of fistula, for example. Things like colostomy bags are those special bags that are used for patients who have had their diversion. We find some of these things are also like taxed. They don't reach the patient in time. The facilities are asked to pay a lot of money for this. So some of these things actually should not be taxed. The government should really help out some of these cases that are so needy, that patients with cancer, cervical cancer, who have colostomies, these things are so, can I say, priceless, because they give these people or patients dignity when they are wearing them. They should not be taxed, because it gives a woman some decency when she's wearing it. She can go to church, she can go to work in her shamba, she can actually go to visit her friends. She can even engage in a meaningful work. But when you tax these kind of things and then you keep them in the warehouses for months when these patients are suffering out here, I think it's not fair at all. We need to do refresher training. Once a surgeon has actually finished the training, we should do refresher courses whereby we kind of re-inform them again about complications and what they should be able to do when they meet a complication. So retraining is very important. Refresher courses are very important. And I think for some countries they do, apart from CMEs, they do actually even exams every few years, so that we keep abreast with the knowledge so that we don't forget. And that one can help us reduce the numbers.
In an attempt to lower fistula cases countrywide, there are over 5 hospitals offering fistula surgeries and care as compared to 20 years ago.
Since the last 20 years, we have kind of revolutionized the care of fistula patients. That means we have actually now available facilities. We have Geno Care Women's and Fistula Hospital. We have a center in Kitale. We have Kapenguria Government Hospital. We have Kisii. We have Chama Hospital in Nairobi, KNH, and also we have one in Mombasa. And all these centers are able to operate, and then they refer to Geno Care when they have a complicated case. And the hope is that fistula surgery or fistula is preventable 100%, apart from causes of congenital cancer. Even cervical cancer is preventable if the patient goes to screening early. There are also girls who get sexual assault, which is a very sad thing. That fistula care program, if you walk to Geno Care, you'll see maybe 3 young girls who have been sexually assaulted, and actually they have a fistula, which is really sad. They are 6 years old, and they come in hospital with terrible injuries there, and we have to operate them and even take them to school in an environment which is far from where they live. So I think the hope is that fistula is preventable and the fistula can be repaired if the patients get to a center which has a qualified personnel. And we are hoping that the government can look at it and see how to formulate policies to prevention, training of doctors, because if the government also gets involved in training of these doctors to be fistula surgeons, then the numbers would actually increase. Because as we speak now, the government has not been training doctors for fistula, or the doctors trained have been trained by donors and other people. But if the government trains them, then there's hope for the number of fistula surgeons increasing and then reducing the backlog. Yes.